and welcome to today's webinar, Suicide Prevention Standard Operating Procedures for the Pediatric Primary Care Office. I'm Megan Crosby-Buttinger, and I'm the Program Director for Maryland BHIPP. We've organized today's webinar in order to provide some background and technical assistance just in helping PCPs address youth suicide prevention in their practices. Before we get started, I wanted to go over just a few housekeeping details. And while I do that, Grace, if you could go ahead and put a link to our pre-webinar survey in the chat. This was emailed out to any registered attendees earlier this week. If you have not already, please take a few moments now to complete that. It's just a couple questions, and it just helps give us some feedback about our webinar so we can continue to improve upon them. So today's WebEx webinar is formatted in such a way that the presenters and panelists and their slides are featured. So you'll notice that you're not able to turn on your video as an attendee. However, you can unmute to ask questions, and you can certainly drop questions in the chat, which Grace will help us monitor. And we'll also plan to leave some time at the end for any further questions. Okay, it looks like Grace dropped that survey in the chat if you want to go ahead and take a look at that while I introduced our guest presenter for today. So I'm pleased to introduce my friend and colleague, Dr. Mary Swick. Dr. Swick is a licensed psychologist and earned her doctorate from Southern Illinois University. She completed her fellowship at the Johns Hopkins Division of Child and Adolescent Psychiatry and is now a senior scientist and associate director at the Center for Indigenous Health, which is at the Johns Hopkins School of Public Health. And she also holds a joint appointment in the Department of Psychiatry there. She has over 15 years of experience conducting suicide prevention research with a special focus on American Indian and Alaska Native communities. She serves on the Suicide Prevention Resource Steering Committee, APA's Committee on Human Research and Zero Suicide National Implementation Team for American Indian and Alaska Native communities, and served as the lead content expert on a recent SAMHSA guide for evidence-based interventions for youth suicide prevention. So Dr. Swick and I first met at Johns Hopkins, and we worked together for several years on the Garrett Lee Smith Youth Suicide Prevention Program, where we oversaw the implementation of evidence-based youth suicide prevention efforts across the state of Maryland. So welcome, Dr. Mary Swick. Happy to have you today. I'm going to go ahead and get our slide deck up. Bear with me just a moment. Okay. All right. So before we get into the meat of our presentation for today, I just wanted to take a couple moments to just go over BHIPP briefly and what we offer. So our main goal at BHIPP is to offer support to pediatric primary care providers who are addressing their patients' mental health needs. And so we do that in a number of different ways. Our primary way that we do that is through our telephone consultation warm line. So the numbers listed here, any primary care provider or emergency department provider in Maryland can call us with clinical, diagnostic, medication, treatment questions. We also are happy to provide assistance with resources and referrals. We have a pretty sizable referral database that we keep updated for resources across the state. We also offer a lot of free training and continuing education, such as today's webinar. And we do have a Project Echo. We have 2 clinics running right now, and that is kind of a remote team-based learning. Primary care providers bring cases to share, and members of our BHIPP team, who are child psychologists and psychiatrists, help facilitate a discussion around that and also do some didactic presentations as well. So that's kind of a learning cohort model. The other thing that we're really proud about is our social work co-location internship. So we have social work graduate students who receive a specialized year-long curriculum with us, and they're placed in pediatric primary care practices in Southern Maryland, Western Maryland, Eastern Shore, and Baltimore City. And last but not least, we do have some telemental health services. We offer care coordination. We do have some limited slots for telepsychiatry as well as psychological evaluation. So that's just a brief overview of BHIPP and what we offer. Just want to briefly mention our partners in funding. So BHIPP is a collaboration among multiple different universities. Our day-to-day operations are handled at the University of Maryland and Johns Hopkins, but we also have partnerships with Salisbury and Morgan State universities around our social work co-location, and also do some training and technical assistance with the University of Maryland Eastern Shore. This training today is funded through an emergency COVID grant that came to us from SAMHSA, and we do have braided funding from the state as well as from HRSA. Okay, no disclosures. Briefly, our learning objectives for today. So we're hoping to describe the rationale for screening for suicide in the pediatric setting. We want to give some guidance around selecting the appropriate tools, and also some guidelines for how you can create standard operating procedures for your office to be ready for when these types of situations come up. And without further ado, I'm going to turn it over to you, Dr. Swick, and I'm happy to advance your slides for you.
Thanks, Megan. Welcome, everyone. So I have the pleasure of getting us started, which is kind of setting the stage for the significance and the rationale for why suicide screening is so important. And so we just have a snapshot of some up-to-date data on the next several slides for you. So if we look at suicide in the United States, kind of across just all age groups, what we see is almost 50,000 Americans die from suicide each year. And we know that's an underestimate because we know there's a lot of underreporting due to stigma and other reasons. If suicide sometimes will fluctuate between being around the 10th and 11th cause of death, but the most recent estimate has it at 11. In addition, this third bullet is one I think that always surprises me when I see it, even though I've probably seen this quite a few times in different presentations. But suicide has surpassed motor vehicle accidents as a leading cause of injury-related death, and that's probably for a couple of reasons, right? We've gotten better at preventing injury from motor vehicle accidents, and suicide has been increasing. But I think that just really sets the stage for how important of a problem this is. The other thing that's I think is really important is to understand we are seeing some increases. People are always curious if the rate's decreasing, staying the same, or increasing. And I think right now it's hard to say because with COVID, everyone's wondering kind of what's happening. But sort of the latest statistics that we have are showing a 4% increase from 2020 to 2021 after 2 years of decline. And I think we'll just have to sort of see what happens over the next few years to understand that pattern. But I think something for this audience that's important to understand is this large increase really happened a lot among 15 to 24-year-old males, which will probably be some of your patients that you're seeing in your clinics and in your settings. The other thing we will also see that's not on the slide is if you look, sometimes we will see a decrease in the suicide rate in certain years. And I think I would just always caution folks to know that sometimes in certain racial ethnic subgroups or certain age groups, there is actually an increase, but it's masked by that overall decrease. So it's just important to understand that. Next slide, please. Thanks. So if we look at youth suicide, first of all, we know youth are not dying of a lot of things, thank goodness, but the things that youth are dying from, suicide is in the leading causes of death. So if you look at 10 to 14-year-olds, it's the second leading cause of death. And for 15 to 24-year-olds, it's the third leading cause of death. And generally, these are pretty stable. It's never been the first, but they're always around 2, 3, 4 in certain age groups, depending on what year you look at the data. And then for 2020, again, we don't always have the most recent year's estimates because it takes a while to get the data. There were over 6,000 deaths among U.S. youth, and that's just a heartbreaking number because we're losing these lives too early and could be preventable. Next slide, please. Again, here you can kind of see that what I was alluding to a little bit earlier about how the rate can change over time. But if you look here, we've got through 2020, and this is for ages specifically 10 through 24. You see that there was kind of an increase in the middle of our time frame there, and then it sort of started to plateau and then go down and up again, right? So, towards 2018 and 2020. So it's kind of hard to know what's going on there, but it's if you even want to consider it a plateau, it's at a high rate, right? So we'd love to get that rate back down to where it was in the early 2000s. Next slide, please. The other thing I think that a lot of national agencies and U.S. providers are probably becoming aware of is that we're seeing suicidality in younger and younger age groups. And we don't know a lot about it, but we're starting to try to understand it better. So these data are imperfect, but I think they help to just give us the sense of what's happening among that younger age group. So we do know that children under 12 plan, attempt, and die from suicide, and that specifically it's the second leading cause of death for 12-year-olds. And if we look at under 12, it's the sixth leading cause of death. Here you can see we have numbers from 2016, which are likely underestimates. And again, we know that these aren't perfect, but just to give you a sense, some people like to see the rates. Some people like to see where it is in the leading cause of death. And for some of us, like seeing the numbers are like what's impactful. And so if you look among 5 to 14-year-olds, so there was in 2016 a 5-year-old who was who died from suicide. That's what it was classified as. There were a little over 400 deaths. Which is just, it is shocking, right? It's one thing to think about that kids this young are maybe talking about it or thinking about it, but that they're actually, some are dying. It's especially tragic. So again, I think this is starting to get more attention in the research and attention nationally. Next slide, please. Thank you. And then this slide here gives us a little bit of a snapshot by different races and ethnicities. So you can maybe reflect on what's the patient population you see in your setting, in your clinics. But here we can see a couple of different things. And these patterns generally have held true through different years. You can see that the darker blue is males and that the red or pink is females. And what generally males among all racial and ethnic groups are going to have higher rates than females. But you can see the discrepancy, right? Like between that might differ. How big of a gap it is for different races and ethnicities. The other thing you can see here is that American Indians and Alaska Natives in general have some of the highest rates. And Megan alluded to that's one of the populations that I specialize in helping. The other thing I want to talk about a little bit here is that the Black bars for African American or Black youth, what we've seen is really an increase in that population too. So that's not necessarily captured in this graph, but I just want to highlight that for you, that we're really seeing, especially in, I think, 10 to 14-year-olds, we're really seeing increases in suicidal thinking and suicidal deaths among young Black men and young Black women. So if that's a population that you work with, just it's important to note that. Next slide, please. Great. And then here we wanted to show you a little bit about the methods. This is, again, just an article that this is pulled from. It'd be interesting to kind of see a more recent pool of this data to see how it's kind of changing and evolving over time. But what it's really targeting for us is just to think about the means matter in a way, right? And especially as a clinician and in your practice, right? We're going to be talking about safety planning later in the presentation. And if you were to do a clinical interview, you'd want to kind of be asking about these different methods for the youth that you're seeing. And so you can see there that overdose or poisoning has been typically the lowest of the method. Again, this is for suicide death. Okay, if we looked at attempt data, it might look a little different. And then we can see here that firearms in this time frame was starting to show a decrease in being one of the leading methods. And at that same time, hanging was increasing. And so there's a thing in the literature called like mean substitution. And, I don't know if we could argue how true or not it is, but this graph is kind of interesting because it makes you think about that, right? As one means becomes less available, then another means maybe becomes more popular, so to speak. And so we could think about maybe different firearm regulations that were during this time that maybe made it harder for youth to use guns as their means of suicide. But I think today we are seeing, at least in the adult population, and so I'd be interested to see how it transfers to youth. We are seeing a lot of firearm deaths, and it's gotten a lot of national and local attention in suicide. So I think we still want to pay attention to that. Next slide, please. And then we think about like the suicide deaths are really a smaller part of, we think about kind of the pyramid of suicidal thoughts and attempts and behaviors, right? They're the most impactful, but the smallest part, right, of that triangle. They're kind of the tip, or if you inverted it, they're kind of that smallest part, right? And then each behavior gets a little bit bigger and bigger. So if we think about attempts, and this data usually comes from things like youth risk behavior surveys that you all might be familiar with. About 2 million people attempt suicide annually, young people. And here you can kind of see the percentages. I won't go into all the details here in the interest of time. The other thing that strikes me, because I've done a lot of work in emergency department settings, and some of you guys may also have worked in that setting too, or seeing patients coming from that setting. It's nice that the emergency department staff or doctors will kind of ask, isn't this more of an adult problem, or trying to kind of really understand it in youth, especially if they're not a youth specialty doctor. And this statistic always sort of hits me. So if we looked at ED visits for attempted suicide in children less than 14, it's actually about the same amount as for adults greater than 50. And we know that that's another high risk group for suicide. So I always think that's an interesting statistic there. Next slide, please. Great. And then if we look at just thinking about suicide, right? So it's kind of like now we're getting kind of to the base of that pyramid, or the fattest, so to speak, part of the pyramid. These numbers are just a little higher than the attempt numbers, but again, they're probably underestimates. But about 2.5 million high school students report seriously thinking about suicide in the past year. And so again, I can think about the volume you guys see in your clinics or your different settings. And if you kind of could do the math there, you would probably be able to figure out, gosh, on average, about how many of my patients probably have thought about suicide in the past year. So it might be interesting for you to kind of try to do the math there. But the other thing we want to highlight here is that younger age, because a lot of this youth risk behavior survey data and just a lot of the better data is on adolescents. And like I said, not as much on younger kids. But we have some research that shows about 12% of kids 6 to 12 have suicidal thoughts. And I know that when we were setting up screening in the Hopkins emergency department here, we were trying to debate how young to screen kids for suicide. And they really wanted us to start younger because they said that's what they're seeing in the ER. They don't go as young as 6, but sometimes they've been screening as young as 8 and 9 year olds because they're seeing it in their setting. Next slide, please. Great. So we're going to transition a little bit. I know that was a lot of data, and I saw a lot of great sharing of resources in the chat, and we can answer any follow-up questions about that. But we're going to transition into talking about screening. So hopefully we've set the case that this is a significant problem among young people and even pre-adolescents. And so, but why is primary care a place that we would want to intervene? And so I think that's what we're going to talk a little bit about next. And I think there's a lot of good data that really shows that for both adults and young people, that they have had contact with different kinds of medical providers in the months and year leading up to their suicide death. So here we have a study that showed 80% of adolescents had contact with a medical provider, within 3 months of their suicide attempt. And we know that many of these youth may not be in specialty mental health care services, right? So this might be their touch with the healthcare system. In addition, 50% of youth had been to the emergency department within 1 year of their suicide death. And I think it's also important here to highlight, in these settings, they're probably coming in for somatic complaints, physical problems, things that kids usually will come to the doctor for. But, right, they also were maybe having this suicide ideation potentially that could have been detected. And so that's why we really think, because primary care providers, all of you and those that you work with, are really one of the providers that sees young people really regularly, right? They've got, child visits, they've got to get vaccines, they've got to get sports clearances. So they're seeing you guys more regular than they might be seeing other providers, especially for those who maybe even are coming from more disadvantaged populations as well that don't maybe have other resources. They maybe are going to that ER or to their primary care doctor. Next slide, please. So again, there's a little bit of debate and thought and question around who should we screen for suicide risk. And here we've really got kind of the current best guidelines. They do sometimes evolve. So I think that's important to note. One thing we do want to talk about, though, is we'll commonly get a question from people who don't work in this field, like, well, is asking about it going to make them suicidal or make them think about it? And there's actually really good research that shows it doesn't, right? So just asking the question is not going to put the idea in someone's head. So we really do have solid research showing that. It really just, if someone has maybe ambivalence about it, maybe has that thought in their mind, but hasn't been brave enough or decided to express it to anybody, us asking, maybe it gives permission for them to voice it. And there's actually been some qualitative studies where youth have said that they're glad to be screened and they're glad to be asked because it shows people care and it gives them a chance to express that to providers if they want to. So I think that's really important. And then here you can see we have a list. So universal screening is really being recommended for youth ages 12 and older. And universal screening means that any youth that age should be screened for depression and suicide. And so here you can kind of see a list of all the organizations endorsing that. In addition, when we think about the younger age group, that's again where it's a little more debate and controversy. And you could do what you think is the best practice in your setting, right? You could always screen more than is the guidelines say, right? So they recommend indicated screening for those who are 8 to 11 years old. And so what does that mean? What does indicated screening mean? It means like when you have a reason for concern based on something else. They've got some other risk factors. Maybe they have a history of mental health concerns. There's just something that tells you like in your gut sometimes, oh, maybe it's worth giving this person a screen because there's something in your clinical intuition or the presentation of that patient where you think it might be a good idea to screen. But you shouldn't necessarily do it for every 8 to 11-year-old in your practice. Next slide. So you might wonder, what are some of those risk factors, right? What might warrant an indicated screening, especially for that younger age group? And so this is, we'll see if everybody's awake enough this afternoon or morning, wherever time zone you are. This is Path Warm. You can kind of see the maroon letters going down, which is kind of a funny acronym, but it's memorable. I never forget it because it's kind of kooky. But again, it's got a lot of good risk factors in it. And I think most of these are going to be things that aren't surprising to you, right? So things like thinking about suicide, using substances, no reasons for living. These are things you guys will probably have been taught or come across. I'm not going to necessarily go through all of them. But I think a couple to point out is anxiety is an important one, and especially more of the agitated state of anxiety. So you've all probably seen, a patient at your clinic where they come in and they are almost like in that panic attack, agitated mode. And it is just like, you could just look at them and see it, right? So that's the kind of agitation and anxiety that we mean. And typically we think of depression, as one of the disorders where you really have high risk for suicide. And that is true, but that's why I always like to highlight anxiety here, because it is just as important not to ignore that. I think the other one maybe to point out at the bottom is anger. So I think sometimes too, maybe males might express things in a way that comes out or looks like anger or recklessness, right? Or certain groups. And so I think we want to not always just ignore that, right? And think that it's just disruptive behavior or acting out behavior, and realize that that can be a warning sign as well, especially these types that we list below when it's sort of this uncontrolled anger and there seems to be this idea of seeking revenge. Next slide, please. So now we're going to talk about specific measures. This is probably one a lot of you might be familiar with, or you might be familiar with different versions of this. So this is the Patient Health Questionnaire, and they have an adolescent version. And here you can see it's been studied and validated on ages 11 through 17. It's nice because it's self-report. They could do it, on paper, on a tablet, and it's nice because it does the past 2 weeks, right? So it's recent enough in time, but it's enough time shot to kind of capture what's going on, right? It's not necessarily 3 months ago. It's a little more recent in time. And it's nice because I think most medical professionals are used to this, or maybe already have these questions kind of in their practice in some shape or form. So it fits in nicely, maybe, in not adding an extra burden. It also lines up nicely with sort of the DSM criteria for depression. And you're sort of getting a 2-for-1 in a way, because it's screening for depression, but then it also has a suicide item there, which is item number 9. So you're able to do a little bit of both and not necessarily have to have a separate depression screen if you use this, and a separate suicide screen. Next slide, please. So here you can see it. We can all like squint our eyes a little bit. I'm always bad at that too, but I think I'm going to tease Megan. I'm getting middle-aged eyes, but so you can kind of see here the questions and how you would proceed and score it, just so you have it. And I think we have these shared in your guys' references. And then the nice thing about it is there's scoring guidelines, right? Which is really nice. So here you can see, again, from none to minimal up to severe, you've got the numbers, and you can see what the recommended steps are, which is really nice. So some of it can be just as simple as like reviewing, you had a negative screen, but just opening up the conversation if they have any concerns or things they want to discuss. And it can go all the way up to an immediate referral, or maybe a more emergent kind of situation. So I think this is a really nice chart for you guys to kind of keep and utilize. Next slide, please. So again, I think the other thing we want to just remember, and I've hinted about this a little bit too, is like depression is important, and that is a big risk for suicide. And you do have that suicide question on the PHQ-A, but there are other risk factors, right? So there might be other times where you want to ask about suicide just based on other things that are going on with the patient. Maybe you didn't screen that patient, or maybe that patient's screened negative, but there's other things going on in their life, right? So these screens are meant to like supplement and identify people who you might not have realized are at risk, but they're not ever meant to like totally replace your or the staff that you work with, their clinical judgment, right, or skills. They're all just tools. And so here you can see some other risk factors. I think the interesting thing is, right, we sort of can say like any of us could probably raise our hand, right, to one of these risk factors maybe. So it's tricky, right, because it's like these help us understand like on a population level kind of what the risk factors are, and they're things to be aware of with your patient. But sometimes it's hard to kind of get in a little bit in the weeds with them. But there are always good things that you can ask about in your clinical interview with a patient if that's what you would be doing as your next step. Next slide.
Mary, we did have a question
Yeah.
in the chat. Somebody, and I apologize, there have been some questions that we'll be sure to get to at the end, but this one.
Yes, and I can type in the chat too during your part of the presentation as well.
I think this has relevance to what we're talking about now. Someone's asking for a good screening tool for 8 to 11-year-olds.
Yes, that is such a good question. I don't know that we can 100% say, but I think a lot of folks are starting to use the ASQ or the ASK for younger age groups, just because there is a little bit of data with that. I actually think I have a paper on it, but so I can put it in the chat. But so we're starting to use that one. But again, there isn't like definitely a gold standard for that young age group, but that would be one to look at. And that's an NIH tool, and we may have included or will include it in your resources. So it's free, and there's a lot of resources on the NIH website as well. And you could consider using that if you're not already wedded to the PHQ-A. You could use that ask for potentially as your screener or as a second screener. So there's a couple that people are using, PHQ and ASCM, and then different versions of the CSSRS. Woo, has a screening version. Those are probably like the three screeners that are kind of the best, have the best data, but none are perfect. They all have some strengths and limits. But again, I think the ASQ is the one that at least has a little bit of data in young people. So thank you for that question. It's really important. Great. So now we're going to talk a little bit about assessing risk level. And again, this might be something where you have someone in your clinic or someone that you'll refer to that will do this part of the process, or you may be doing part of this process. So we'll kind of give you a nice overview here. So next slide, please. Thank you. Oh, there we go. So again, I think, from your guys' perspective, in a primary care office, which is, where you're where I think most of you guys are housed, it's really just trying to understand, can the patient and the parent keep their child safe, right, until they're getting help or counseling or services or whatever is kind of decided as the next step? Can they provide that appropriate supervision? Do they feel comfortable? Or do they feel like they can't provide that supervision, right? And it's something that they may themselves admit, upon questioning, or be willing to say that, or it may be something based on your observations and knowing the family and asking questions that you don't feel that I'm comfortable with that. So it's kind of a mix both, right? It's kind of how they are saying about it and kind of what you judge kind of based on everything you're hearing and seeing. So again, if they can, I think ideally most people can be kept safe, I think, especially if they have the proper education and training and do a really great safety plan, which is going to be the next part of the presentation. And if they can't, then you'll have to consider going to an emergency alternative such as the ER. Next slide, please. So again, we're kind of going from that screening where we focused on the PHQ, and there's a couple other tools, to the next step is going to be this risk assessment, right? And you can do this in a couple of different ways. And for today's presentation, one of the ways that we are recommending is using the CSSRS. I think it's pretty well known. And there's a lot of resources with it, and it is one of the gold standard risk assessment tools, but there are other options. I'm happy to take questions about that later. But it's nice because it really provides a framework for kind of asking these questions, and it really does kind of ask about all the types of suicidal thoughts and behaviors in one instrument, which is really nice, some ranging from ideation up to, an attempt with a plan and prep. So you get sort of a lot of great detailed information, which really helps you to understand where this patient, where this young person is. It also helps you to understand their severity and frequency, right? Because you might have a different level of concern if it's the ideation seems mild and maybe it happens occasionally versus it's pretty serious thoughts that they're having them every day, right? So that I would treat those patients very differently or make a different recommendation. And so this tool helps you to kind of figure that out. So it's really nice that way. Next slide. Again, here's a little bit, and they have a lot of resources on their website. So we've got their website there. I feel like they're constantly updating and evolving that. And there's lots of different versions of the CSSRS, which is really nice. So there's the screening version. There's kind of the traditional risk assessment version, which we're recommending. There's even one if you have clients or patients that this is more of a persistent issue for them, and you have to maybe give them the CSSRS every time you see them, so to speak, because it's just a chronic issue. They have this since I last saw you version, right? So that's nice. So they have a lot of nice options there. And then they also do have, again, some scoring guidelines here to help you know what to do, right? And so this positive answer to question 4 or 5, right, really indicates a higher level of risk. And then even any suicidal behavior in the past 3 months, they recommend, so an attempt, they recommend to consider that also as serious, because we know that a past attempt is one of the, from a statistical standpoint, best predictors of a future attempt and death. So it's a really significant risk factor. And I think we've got a snapshot on the next slide. of the scale. Yeah. And it's like you can even do this color coding, right? Which is where you can see 4 or 5 kind of have this more like almost orangey red kind of like emergency color to kind of help you know kind of how to score it. And so it's really nice there. And then you always, no matter what, you always ask that past history question in the past 3 months to really understand that again, because it's important to know that about your patient. Next slide, please. Wonderful. I think we're going to be transitioning next to safety planning with Megan.
Yes, thank you so much. Thank you for all that information. Yes, we're going to transition now to talk about a safety plan. So after you've assessed the risk level using some of the screening and assessment tools that Dr. Swift described, if suicidal ideation is present, you're going to want to create a safety plan with that child or teenager. So just a little bit about safety planning. Um, so I worked myself in a primary care office as an integrated behavioral health person, and a lot of the language was about contracting for safety, and I would read that in notes sometimes. And so the recommendation is not to do a no suicide contract. The evidence-based recommendation is to create a safety plan. So that's a collaborative plan that you come up with the patient and the family in the case of a young person. Um, and so what you're doing, and I'll show an example in just a moment, what you're doing is starting with things that the youth can identify themselves in terms of their own personal risk factors. And then helping them to come up with and document, to write down specific coping strategies that they have, people they can, go to if they need help and things like that. And so there's a template that you can use, and you'll sit and have this discussion. You'll keep a copy in your practice in their chart. You'll send the family home with a copy, and you want to encourage them to use this safety plan in between visits as a way to stay safe and take care of themselves. So um, the next slide here shows the Stanley Brown template that I have used the most often in private practice. So again, you're guiding the patient through a discussion of what are some warning signs that you're not doing well, that you're starting to have some suicidal thoughts, or this could be a tough day for you. And so you're helping them, and that is therapeutic in and of itself, just helping them to be able to know those things about themselves and jot them down. And then you're walking them through what are some internal coping strategies, some things that you can do to help take care of yourself. And this is going to vary from person to person, right? We all have our own individualized strategies that work the best for us. For some people, it might be going for a walk. For someone else, it might be listening to music, or playing with their dog or something like that. So you're going to help them list out some coping strategies. The next level is, who can I hang out with? Who can I spend time with that can just even provide distraction? We don't necessarily need to, talk about my feelings of depression or talk about the thoughts I'm having, but I just want to kind of try to have some fun or be distracted today. So this, for a young person, this could be friends, this could be someone they play with in the neighborhood. And then also helping them to identify some places that make them feel good. So maybe they want to go walk around in the mall. Maybe they want to go for a hike in the woods, and just kind of helping them identify those. The next level is people who they can ask for help. So when I have created these with young people, I guide them toward identifying adults. So it feels maybe a little more comfortable for them to tell a friend or a significant other about the thoughts that they're having, but that's a lot of responsibility for a young person, and we want to get them to a trusted adult who is in a position to get them to intervention or care, and to get the attention of a clinician. So I encourage them to think about, are there adults in your life who you could go to for help? So maybe this is a parent or grandparent. Maybe this is a coach, a teacher, a school counselor. a religious leader, things like that. And then wanting to document and write down the professionals that they can reach out to. So your name and number would be down here as their primary care provider. If they also have a therapist, you'd want to help them put that information down. Any local services, if you have a mobile crisis team in your area or a walk-in clinic in your area. And then this lists the suicide prevention lifeline. Just this year, we've transitioned to 988, which we're going to make sure to send out a flyer about that in your resources. So 988 is a nationwide number. And basically, it's going to connect you to the closest crisis phone line service to you, based upon where what number you're calling from. So that would be kind of triage to a local crisis call center. And then making the environment safe, which I'm going to talk about in just a moment. So this is an example of a completed safety plan. It looks like this one might be for someone a little bit older, maybe a teen or even an adult. So you can see they've listed out some warning signs for this person: having suicidal thoughts or urges to drink, arguments with significant other. They identify a couple of internal coping strategies, and then social situations and people that can help distract me. So you see here they have an AA meeting on here. They have getting together with their cousin, going to a local coffee shop. And then when it's people who I really need to ask for help, they've identified people they can trust to get them to a safe place or to treatment if needed. And so that they've identified their mother, or they have an AA sponsor, some professionals or agencies they can reach out to. And then last but certainly not least is making the environment safe. I think on the version of this that I use, yep, down at the bottom, the one thing that is most important to me and worth living for is, so helping them to identify and document that as well. So just wanted to talk a little bit about making the environment safe. So there's this counseling on access to lethal means, CALM framework that you can use. And it goes into great detail about all different ways that you can intervene depending on what the risk factors are. But just briefly, you want to be involving family in this discussion, in particular with children and teenagers. Their caregivers or their parents are going to be the ones helping to make their environment safe. So they need to be aware of the plan in terms of, are we going to need to remove a firearm from the home? Are we going to need to, use a pill box, or parents have, monitor medication, things like that. So some examples of kind of common ways to make the environment safer. You need to ask about firearms, if there are firearms in the home. I don't know if you recall in one of the earlier slides that Dr. Swick presented, just having access to firearms increases your suicide risk, even independently of, whether you have an identified mental health condition, just having that access. So wanting to ideally remove them from the home, even temporarily, or ensure that they're locked and that the youth doesn't have access to them. Similar approach with medication, so limiting the quantity of any potentially lethal medications. This might mean having parents keep it in their bedroom in a lockbox, or the parents administer the medication, or give the teen a pill box each week if they want a little bit more independence, if that's a okay amount for them to have, things like that. And then alcohol is another big one. So we know that alcohol disinhibits us, and we may do things under the influence of alcohol that we may not otherwise do. And so that's also a risk factor if someone's using alcohol. So again, ideally removing it from the home or finding a way to keep it locked up. Some additional considerations for youth, making sure that parents know that they need to be supervised. So this can be tricky because if you're dealing with a teenager who's also wanting independence, You might kind of have some butting of heads there. So you want to emphasize that you're, not leaving them alone because you care about them and you want to keep them safe. Um, Try to increase the time they spend with their family, and also monitoring social media. So again, some of these things they might not be thrilled about, but just wanting to emphasize that it's about keeping them safe and make sure that they know that you're doing it and why you're doing it. You're doing it because you love them, you care about them, and you want to keep them safe. And so you can, if there is pushback, it's sometimes easier to devise a type of check-in system. So people use different methods for this. You can use color codes, like how are you feeling today? Red, yellow, green. You might have keywords or things like that, but adopting a way to check in with your child or teenager in a way that doesn't feel overly annoying or intrusive to them, but allows you to check on their safety. And it says here, the goal is to assess safety, not to manage your anxiety as a parent. So that's an important key as well. Okay, so this is a little bit of a busy slide. So I apologize for that. These guidelines come to us from the Suicide Prevention Resource Center. And so they have created a toolkit that is really helpful that we're going to make sure you get in your resources after today, for creating a comprehensive approach in your primary care practice. So the first thing they recommend is that you establish a clear written SOP for managing when a patient presents to your practice with active suicidal ideation. So, not just having a discussion about it or not just assuming that everyone knows what to do, but really sitting down and writing out your procedures for your office and making sure to train all your staff in those procedures. So not just the clinicians, not just the primary care providers, but also your front desk staff, your medical assistants, everyone on your staff needs to know about this protocol because they all might be called upon to assist. The front desk person might need to make some phone calls for you or might need to cancel or, notify other patients that you're running behind because you're dealing with an emergency, or you might need somebody to, sit with the patient for a moment. So everyone needs to be aware of the protocols, and it's important to implement a dry run with a mock patient. So when I worked in primary care coming in as a mental health professional, I didn't have a whole lot of training on the medical side of things, and I had to be trained and participate in using a crash cart with the rest of the team, because I could be the one in the room, with the patient. And so similarly to other types of emergency drills that you may have for your office, you want to do a dry run for this type of event that might come up. Um, it's great to have your whole staff participate in an evidence-based suicide prevention training. A lot of these are now available for free through your local health department. And we would be happy to send out resources on that as well, if folks are interested in that and you're having trouble locating that. I think between Mary and I and the rest of our team, we could help you locate a training for your staff. Also creating referral relationships with local behavioral health practices who are willing to take on a youth or teenager who has suicidal ideation. Not every therapist has that as their specialty. So, you can certainly call BHIPP and we can give you some resources in the area. And then it's up to you to kind of build those relationships with those providers and figure out who you like to work best with and who you want to refer to. They advise that you keep paper copies of some of these screening tools. I have had the power go out on me when I'm at work with a patient. So it's good to keep a paper copy, even if you use an EMR. Make sure you have those screening and assessment tools handy so you're not, rushing around looking for them. And keep an up-to-date list of the crisis resources. So we're going to be sending you a 988 flyer. They have a bunch on there's a Maryland 988 page now. webpage that you can go to and download these resources for free and print them out, post them in your clinic, making sure that you have the numbers for any local crisis services available, including crisis teams and walk-in clinics, and knowing your local emergency departments, and maybe knowing which hospitals you prefer to send children to with this type of emergency. Some other considerations when drafting your SOPs, I'm going to move a little bit quickly through this so we have some time at the end for questions, and we'll make sure you get these slides. But just thinking through who, the who, what, when, where, and how. So who on your staff will be the one to make the phone call if necessary to mobile crisis or 911? Who will be responsible to stay with the patient to make sure that they're not left alone when they're in your practice? You know, understanding that other patients may need to be canceled or rescheduled or moved to a different provider if you're managing an emergency. Figuring out if anyone else needs to be contacted, including maybe your medical director or an emergency contact. If this was like a 16 or 17-year-old that came in on their own, making sure that you can reach their parents. It can be helpful to help the parent or guardian know what to say when they arrive at the hospital. It's also helpful to print out for them the cover sheet or most recent encounter note to take with them to the hospital. If they have that to give them upon arrival, that has all their most recent vitals and a note, you know, from your encounter. You could also include your screening tools that you just did, and have them sign a release so that you can, you know, speak with the hospital personnel. Let's see, figuring out when you're going to check back in with the family, and how will the patient be transported to the hospital. So if it's determined that the patient cannot stay safe, even with a safety plan and, you know, support from parents or caregivers, share this with the family and determine where they're going to go together, talk about options and how they will be transported. So you'll want to help the parent assess whether or not they can transport them safely on their own. You know, do they have a car? Did they take public transportation to get there? If not, then you may be calling your mobile crisis team. Or if the child or teen is very agitated, or if you have a concern that they might do something impulsive on the way to the hospital, like open the car door, right? One thing to be aware of that was shocking for me the first time that I encountered it is that if you do call, be aware that the patient may be transported in the back of a police car. So I always like to prepare families around that. So, because that can be a little bit stigmatizing, I think. But sometimes that's the safest way to get them to the hospital. Okay, we're going to include this template. This is a fill in the blank template that you can use in your office. So we'll make sure to include that. That has some of the information that we've talked through, some of the questions for you to think through. And then last but not least, it's very important to document everything that you're doing very carefully in your medical record. So the results of screenings and assessments, your clinical rationale, your risk level that you assess, the steps that you took to keep the child safe, including instructions that you gave about reducing access to lethal means, and your follow-up plan. So just having really good, clear documentation can be helpful. So I'm going to stop there so that we have time for any questions. And I'm sorry, I did see a couple things pop up while I was talking. So I'm not sure.
I tried to answer some of the questions in the chat, Megan. Megan, I don't know if you have expertise in ERPO. You may know a little bit more about that than I do, especially in the context of children. So I don't know if there's, I shared a Maryland resource, but I don't know if there's anything you want to add about ERPO.
I don't know if I'm familiar with ERPO.
Okay. It's a way if someone, you know, is at risk to kind of get their firearm away from them.
Yes, I do know.
Yes, that's okay. I know it's like thinking of all our acronyms, but yeah, I'm trying to think through, you know, it's interesting because if it's right, the child is suicidal, but it's the parent's weapon. I don't know if I could answer you guys about how that, what the implications are, but I think Megan and
Right.
I could find out for
Yeah,
you
we
all.
can certainly look into that. And I know the BHIPP medical director, Sarah Edwards, did a previous presentation on emergency petition, and she did include some information on that at the end of her talk. And she had a colleague who works more with adults co-lead that talk. So I'm happy to look into that and get back to you on that. And we do have their presentation uploaded onto our website as well, where they go over that in a little more detail, and they have the forms available and things like that. So if folks are wanting more resources, please feel free to visit mdbhip.org. And if you look under crisis trainings, all of our slides and videos from previous trainings will be there by title. Let's see, did we answer? Did you see the question? Can you add that info in the slides?
I think they're wanting the ERPO information in the slides. Like if we could take maybe a
Oh,
couple of the slides from the other one that we think are relevant, maybe drop them into this presentation,
okay.
I think.
Well, what I might do is just ask when Lily sends this out, if she can send out a link to the slide set that's all about that. I think that would be more helpful. Okay, on the EPs. Lily did put our post survey in the chat here. So if you can take a few moments to complete that, it's really helpful.
And I'm happy. I can't remember, Megan, if my contact information is in the slides because I can put it in it
It
is.
is.
Okay,
It was on
good.
the last slide. So I had it up there for like a brief moment, and then I pulled it down.
Yeah, because if anyone thinks of like questions later, feel free to reach out to me.
You can also EP and ask for local LE to transport. Yes. Thank you, Michelle Hardy, for that information. Did you see the previous question about the understanding of why the rate is higher for Alaskan Natives?
I did.
Okay, okay,
I tried to be good on my
okay.
chat responses. I think I got it in there.
It's hard to see them all in
I
alignment.
know.
Helpful and look. Many teens report that their parents do not take their mental health seriously. Some examples I hear, they think the teen is seeking attention. Are there best practices for navigating a situation like that?
Yeah, and I had kind of wrote a little bit about this in the chat too. But for me, like, maybe it could be something that's considered a cry for attention. But I always think to myself, well, something must be um, not going well for that youth or teen to use that as a cry for attention if that is what it is. But I always tell parents, like, I always take any talk of suicide or behavior seriously, first of all. So I think they need to do that. And then I think they need to try to understand if they do think it is more manipulative or what they might call cry for help or cry for attention, like, why would their child be doing that, right? There must be something kind of going on in their lives, at school, with their mental health status, that's kind of leading them to act in that way or to communicate in that way. And it's not, if it is more of this manipulative cry for help kind of way, which again, I think are not in most cases, something's going on that they need help with, right? And there can be better ways that they can communicate and other kinds of coping skills they have. So I try to come out at it that way with parents, but it can be exhausting, if you've gotten some, there are some kids who will just do this, say it a lot, and it is hard on families, right? Because you don't know, do I take it seriously? Do I not? Are they trying to get out of doing this or that? So those families really could use family counseling, honestly, when it's kind of that entrenched and that challenging. I don't know if there's anything you want to add, Megan.
No, I mean, I agree with what you're saying, and that's kind of my line that I use with families too, is if they're saying something that's serious, we need to pay attention. And they could benefit from counseling no matter what, right? Even if it is even if it is a manipulation of some kind, they would still benefit from being in a counseling and maybe in a family counseling situation. There's another question here. I'm just going to read a couple out that I see. Would this safety plan be shared with other providers or in a school setting, educators, counselors? I would say yes. I think that with permission from the family. So the family, some families are reluctant to share with the school because they maybe haven't had the most supportive experiences in the past or things like that. Um, if the child is experiencing suicidal ideation, particularly at school, maybe related to school-based stressors like bullying or peer relationships or academic stress, I think it's very important for the school to be aware of that. Um, but I think that's something that you'll make that recommendation to the family, make sure you have their permission, and then even have them share it, or you can get a release so that you can share it directly. If that answers the question.
And Megan, I think there's a follow-up about the safety planning one. I think if I'm reading it right, I think it's meaning safety planning. Is planning necessary for a child who cuts for attention? Like maybe would you use safety planning in that situation or not?
I think that would depend on whether or not there is suicidal ideation present, because there are certainly times that people self-injure without suicidal ideation. And if there is not suicidal ideation present, then other therapeutic techniques would be used to reduce the self-harm. And so it actually might look similar, I think. You're still going to be making a plan with your patient around how to do other things instead of cutting or um, reducing triggers and giving them more positive coping strategies, things like that. So you are still going to be making a plan around that, but it would just probably look a little different if their intent is not to end their life. Would you agree with that, Mary?
I definitely would. One thing I wanted to like, it would be harder maybe for you guys because you know may not see your patients, you know, as regularly enough to understand this. But I've had youth, and I just want to kind of explain this a little bit. Who they sometimes change the way they talk about it. Right. So you might ask them about this behavior that they did. And maybe like in that day, they're like, no, I wasn't thinking about suicide at all. And then you might, like, I've had, you know, long-term patients, and then that same incident might come up later, and then they're talking about it as having suicide ideation. So just kind of, it's just interesting thing to be aware of, that kind of like, and youth aren't necessarily like manipulating you in those circumstances. There's like a lot of ambivalence and about suicide and overlap that can be between these two behaviors. So it's just something to kind of keep an eye out for. I mean, there are some of those people who, like Megan said, are just chronic cutters and they never have ideation, but there are some people where their kind of way they think about it is kind of fuzzy and it goes back and forth. So I think it's something for you guys to be aware of.
I'm just looking at one last question. I understand people might want to hop off, and that's fine. I'm happy to stay on and try to answer some of these. Someone is saying, if an adolescent has passive suicidal ideation with some self-cutting history and parents are totally unaware of this, how do we best take care of this kid while we have several patients still waiting to be seen? A suicide screen followed by counseling, a safety plan can take at least an hour, and we cannot just reschedule them without making sure the kids are safe at home. I completely understand. I think um, you're right. You can't send them home if you're not sure if they're safe. And so I understand that that would be disruptive to a primary care practice, and it might mean having to pull in other staff to help support, or you know, your front desk might be helpful in moving patients around. It's if you have a waiting room full of patients with ear infections or other conditions that maybe a colleague could see while you're in with the family, creating a safety plan. And some folks might need to be rescheduled, and I know that that's inconvenient, but if you let them know, like me as a mom, if someone said to me, I'm so sorry, your doctor is actually handling a patient emergency right now, you know, I would hope that if my child was having an emergency, we would get the same treatment. And so I think um it's not ideal, but I think you do have to just address it right there and then. One of the resources we'll also send is about billing and coding for these types of interactions. There's some legislation I know that's moving forward right now in regards to collaborative care codes. So we're not quite there yet, but there are some codes that you can use to get, reimbursed for your time, because we understand that these types of visits do take longer. They do take more time, and we know that. So we're hoping that we're moving in that direction where providers will be able to be reimbursed for their time and the care that they're taking of their patients. All right. Let me just see it. I know it's 1:05. If there's any other questions, I think we might have gotten them all, unless I missed something. I really appreciate everyone's time today and your attention and all the thoughtful questions that you put in the chat. Please, if you haven't already, go ahead and complete our post survey. And that really helps us improve upon our webinars and gives us some good feedback, and also maybe ideas about future topics that you'd be interested in seeing. Lily from our team will be sending out an email to you with resources, including a copy of our PowerPoint today. We'll have a recording posted on our webpage as well, and we'll send you lots of helpful handouts related to our content today. Thank you so much, everyone. Bye-bye.
Bye. Thank you.